Welcome to America with an Accent. 7 months ago, we talked about how to prepare and save minority groups from a second wave of COVID-19. Did we manage to do that? And what is the vaccine distribution situation for these categories? Dr. Eliseo Pérez-Stable is the director of the National Institute on Minority Health and Health Disparities in Bethesda, Maryland, and joins us from his home in Washington, D.C. Thank you, Dr. Pérez-Stable, for being my guest again.
My pleasure to be here. Thank you for inviting me.
So what is the picture today? What is different from 7 months ago?
Well, I think we're living through the worst possible episode of the pandemic that we could have imagined 7 months ago. Beginning in November, the entire country essentially has been experiencing an excess amount of cases, reaching up to 300,000 cases in one day, averaging 250,000 cases a day over the last couple of weeks. Over 3,000 people are dying every day now. This is like having a 9/11 disaster on a daily basis. And I think the population has become numb, partly a fatigue, partly due to people accommodating to the reality that we have not been able to deter this.
And we're still seeing the disparity among with minority groups. Is that correct?
That is absolutely correct. About 50% of all reported cases of COVID with even incomplete race ethnicity reporting are occurring among Latinos and African Americans. The reason for this is the type of work these populations are more likely to be engaged in. They are essential workers. They're out in the trenches. And second, many of our community members live in more crowded urban settings. These are the underlying factors, and those have not changed in 7 months.
But I was reading about the death rate among indigenous Americans. That's a scary number. If I am correct, it's 133 people among 100,000. We're talking about a population of less than 5 million. This is scary, the death rate among indigenous Americans.
Correct. American Indians in particular have suffered. We know from reports from the Navajo Nation, the White Apache, and other groups that have had severe episodes of the pandemic, but they have successfully managed them in the tribal nations, limiting the effects because of physical isolation and some help. Similarly seen are for Pacific Islanders and Native Hawaiians. The state of Hawaii has been able to isolate more, requiring testing before people travel there, and actually not even accepting tourists until September 2020. I do think that there is some hypothesis that perhaps some populations are biologically more susceptible to severe disease. There's really no scientific evidence to support that hypothesis. It's something that we can continue to explore. We do know that people with diabetes, cardiovascular disease, pulmonary disease are more likely to have severe manifestations of COVID, and these conditions are more common in most race ethnic minority groups. We also know that manifestations are more severe in older people. The highest mortality rates are actually in people 80 years of age or older. Over 100,000 nursing home residents in the United States have died from COVID this past year. About a third of all deaths have occurred in nursing home residents.
In your opinion, is vaccination distribution going as you expected it to go?
As an NIH Institute director, my involvement has been primarily in working with NIH leadership in monitoring the development of the vaccine, and also in the clinical trials that were run by the companies to make sure that at least they had some diverse, inclusive participation of minority groups. Distribution is decided that it was to be left up to the states. That was not our decision. That was made by the administration, and that has been to be at the minimum inconsistent across the country. For example, the District of Columbia, where I live, has now made available vaccine to persons 65 years of age or older. I'm 65. I'm over 65. So I tried to sign up, and all the appointments were taken within a day. I signed up, but I did not get an appointment, so I'm still waiting. The appropriate first group needed to be our healthcare workers, and nursing home residents. Gradually, as more vaccine is available, the groups will be prioritized based on risks, comorbidity, as we say, other conditions, and age. My interpretation of the data are that the biggest risk factor and most common one that we need to target is diabetes.
Okay.
And then people with chronic lung disease and with chronic heart failure or chronic heart disease would be in that same category as well.
Are the minority groups treated favorably, considering the death rate or the infection rate among those groups?
The CDC expert panel made the decision that to target individuals by race, ethnicity was not in the best strategy. Some states, though, have done this. They have used geographic indicators of either poverty or low resources and high proportion of race ethnic minorities to target distribution to certain areas. But to be honest, I think that every state's coming up with their own plan. They don't really have the resources. And this is a massive operation on a scale that country has never undergone before. We are a complex country, 330 million people. The production of the vaccine will be there. We will have enough product to give the appropriate numbers. It will take months. Optimistically, by mid-year, we could see a large proportion of immunizations. More importantly, there's a significant number of people, maybe up to a third, who are resisting or are hesitant to be vaccinated, either because of mistrust or delusional ideas that have been circulated on the internet.
I see a little bit of a problem in reaching these groups, Dr. Pérez-Stable, to be honest with you, because it's what you said. Either the minority groups, and I'm referring to minority groups since that is your area of expertise, but they lack access to healthcare, they lack trust in medicine, in science, and system in general. How do you suggest we convince these people to vaccinate?
Right. Well, we are aware of that, and again, keeping to the target group that I work with the most, the racial ethnic minorities and poor people of any color, the group that has the highest level of hesitancy, as we call it, are African Americans. There is a history of misuse of science in African Americans, but also in other groups. American Indians and Latinos have also suffered from scientific ethical problems in the past as well. At NIH, we launched a program since I last talked to you called SEAL, the Community Engaged Alliance Against COVID-19. Dr. Collins asked Dr. Gary Gibbons at National Heart, Lung, Blood Institute and I to co-lead this effort with funding that was provided by Dr. Collins. We believe the most important communicator on this are local trusted messengers. These could be your local doctor, nurse, your local minister, priest, rabbi, your local community organization person who may not be a politician, but who is known to a local community. And we have pulled together 11 state coalitions led by academics, but in full partnership with community organizations, state or local health departments. We're working with NAACP, the National Urban League, Unidos Us, as community-based organizations. We're hosting or participating really in town halls put on by these organizations, where we present the scientific perspective and answer questions from the audience, all of it virtually, of course. And our bully pulpit as NIH leaders and leaders of color, which I think matters. Dr. Gibbons is African American, I'm Latino, and we are asking our stakeholders, our peers in the academic to really do the best they can in response to this. And we have seen a good response. This started in August, September, and we have seen some slight movement of the skepticism and cynicism early on in October and early November to more receptiveness to this
Okay.
message in the
That's
last month or so. We only had funding for 11 state coalitions right now, mostly in the Southeast, and we're looking to expand this hopefully in the near future to other, at least cities or areas. NIH is a research science-based organization. We also need partnership with all health agencies. The Surgeon General has been very effective in his messaging. We're going to see a transition of the administration, and we fully expect this to be, one of the two
priority.
high
Yeah.
priorities of the new administration.
Okay. I wanted to touch on that vaccination hesitation. I have put together 8 questions that we have received from the audience. If I had COVID, should I still take the vaccine?
The current recommendation is to wait 90 days, but there is no absolute reason to wait. The main reason to wait is to take advantage of the natural immunity most people with a native infection have. Now, if you're feeling ill, you should wait. You shouldn't take it while you're ill.
Can the vaccine used to insert a chip inside a human body?
That's ridiculous. This is a messenger RNA mediated vaccine. It's molecular. There's no chip that can possibly be injected into your muscle. This needs to be proactively dismissed as myth.
Can the vaccine alter the human DNA?
Absolutely not. The injected messenger RNA activates the cell's machinery to generate protection. It doesn't last in the body. It gets essentially destroyed by the body within a matter of hours or days after the vaccine. But it does trigger the cell's own machinery to generate the antibodies.
And this is a different model or type of vaccine from what we're familiar with, right?
Absolutely, yeah. The standard way of giving vaccines in the past, let's say measles, people are used to getting a measles shot. That was a live virus that got attenuated or weakened in the laboratory over a course of several years and then injected into people, and it causes an infection of measles, but that's not infectious, and then it gives you protection on that basis. And so measles, mumps, rubella are all like that. One of the polio vaccines was like that. Other vaccines are killed viruses. So the flu shot is a killed virus, or the hepatitis B is a killed virus. And then that triggers the body to generate antibodies. This is a new mechanism. It's an advancement in science from our investment in basic research. And we were able to generate this as quickly as we were because the basic work had been done over the last 10 years. We had the tools to do it. The effort to be able to do it also was a product of a massive investment in funds by the US government and others, as well as the companies, Moderna in particular, but also Pfizer and the others that committed to doing this. The efficacy of the vaccine, the messenger RNA vaccine, which was originally developed in large part due to basic research done at NIH, actually led by a team that included a African-American scientist, and we're very proud of that, exceeded expectations for efficacy. So having 95% protection from symptomatic disease was far higher than what we were hoping for.
Yeah. Can a touchless thermometer change or impact human DNA or used to insert a chip?
No.
No. Does the vaccine cause infertility?
No. There's no effect at all on fertility.
Are pregnant people or planning to get pregnant recommended to take the vaccine?
That has not been tested, so there's caution about administering in pregnant women, although the trials that have been done, one can look at women who were pregnant at the time they got the vaccine but didn't know it. Because these are large studies, 30,000 or 40,000 volunteers receive vaccine, there's bound to be some women who were probably pregnant at the time. And so, but those need to be looked at. There's no reason to think that it's unsafe in pregnancy or in children. It was not administered to anyone under the age of 18. So there are additional clinical trials being conducted now to look at these questions.
And last question, if someone says, I'm not going to take the vaccine, what advice is there for them besides wearing a mask?
Correct. We will continue to try and persuade them. There is some discussions about using alternative strategies, something in the behavioral economics sphere, so to pay people to take the vaccine. There might be healthcare institutions that implement requirements for workers to take the vaccine. You can't really force people to do it, but we've done very well with the flu vaccine in healthcare workers.
Okay.
And then in the absence of that, the only thing that we can continue to reiterate and recommend is that everyone wear a mask whenever they're going anywhere. They're protecting themselves as well as, most importantly, protecting others. We now know that up to half of new infections are transmitted by people with no symptoms. So the fact that you feel well doesn't mean you couldn't transmit the virus.
Okay.
Washing your hands, keeping physical distance when you're around other people, and absolutely avoiding indoor gatherings with people you don't normally cohabit with. Now, you have to go to the indoor when you go to the supermarket. I'm referring to social gatherings where people go, whether it be a party or a family, extended family get together. These are promoting the transmission.
Well, thank you, Dr. Pérez-Stable, for your time.
Thank you for your questions, and I hope this helps your audience.